Morning or good evening, depending on where you are. Welcome and welcome to today's World Prematurity Day 2024, which we are co-organizing this webinar with UNICEF, WHO, and UNFPA as part of the Every Woman, Every Newborn, Everywhere partnership. And we wish to celebrate the progress that has been made and still remind us also at what we still need to do in order to prevent preterm birth and provide quality and respectful care for women at risk. Preterm birth is the leading cause of death in children under 5. But today we have countries and partners during the webinar, and we'll be discussing the most up-to-date evidence and the progress that has been made to implement known and cost-effective solutions to ensure that every woman has access to high-quality reproductive and maternal care, and that every baby born too soon and other vulnerable newborns can survive and thrive. So a quick snapshot of the agenda. We'll have an introductory welcome by our Director General, Dr. Tedros, the Director General for WHO, after which we'll have an overview of the evidence of vulnerable newborns by Professor Zulfikar Bhutta. We will then have a quick update on upcoming guidance that is coming out from WHO. This will be followed by lessons from country implementation, and we'll have a focus this time on Pakistan by Dr. Mariam Sarfraz from the Ministry of Health, of National Health Services Regulation and Coordination. We will follow that by an intervention by Dr. Leah Greenspan from USAID. And then we'll have a short facilitated question and answer. And we'll close by closing reflections by our UNICEF colleagues. Next. Next slide. So let us go over to the video by Dr. Tedros.
Welcome to today's World Prematurity Day webinar. Each year, around 13 million babies, over 1 in 10 newborns, are born too early. Tragically, complications from preterm birth result in nearly 1 million child deaths annually, making it the top cause of mortality among children under 5. Many surviving preterm infants face lifelong challenges, including learning disabilities and hearing and vision impairments. Most of these deaths and disabilities are preventable, yet these numbers haven't changed in the past 10 years. Countries of all income levels, including China, India, Bangladesh, and Nepal, have demonstrated success in caring for small and sick newborns through targeted investments and comprehensive care. Around the world, WHO is supporting countries to prevent preterm birth and provide quality and respectful care for women at risk. It takes leadership, investment, scale-up, integration, and innovation. We know what works. Our challenge is to scale up affordable, quality, essential care for every newborn and invest in special care units for small sick newborns at district level. Thank you all for your partnership and commitment to saving these young lives and giving all mothers and newborns the care they need and deserve. I thank you.
Thank you very much, Dr. Tedros, for those opening remarks. And before we go to the next item, I just wanted to highlight a little bit what the Every Woman, Every Newborn, Everywhere partnership does. It is co-chaired by UNICEF, UNFPA, and WHO. And basically, the idea is to support countries to achieve increased coverage and quality of care to manage the preterm birth and to reduce impact on vulnerable newborns. And so the partnership has as targets set out the 90-90-80-80, highlighting that we should have 90% of antenatal coverage, we should have 90% of deliveries done by skilled birth attendants, we should have 80% of postnatal care coverage, etc. And so we have now been working with more than 50 countries to develop their acceleration plans in order to achieve these targets, and also for them to be able to share learning. So today is going to be an opportunity really to learn from Pakistan what they have been doing and how this progress is being made. We cannot, of course, achieve the SDGs without looking at, let's say, quality of care. So that's going to be an important component. But of course, there are also huge inequalities, and it's going to be important that we look at these inequalities across the different countries and also look at what is happening in conflict-affected settings where a large part of this mortality happens. Nearly one in 10 preterm babies are born in the 10 most fragile countries affected by humanitarian crises. And so this is also of particular importance to look at. Next slide. So maybe just quickly to highlight some of the existing guidance that is out there, and the slide set will be shared with you so you can have a look at it as well. But there are recommendations on care for the preterm or low birth weight, how to use antenatal corticosteroids, the recommendations on tocolytic therapy for improving preterm birth outcomes, as well as on let's say all the other different interventions to improve preterm outcomes. Having said that, I'm now going to hand over to Dr. Zulfikar Bhutta to give us an overview of evidence, particularly looking at the vulnerable newborns. Over to you.
Thank you, Anshu, and I hope you can see my slides.
Yes.
I am honored and very pleased to talk to you today on a subject that's close and dear to the heart of many people, not just online, but others who are struggling to achieve Sustainable Development Goals 3. I'm going to talk about prematurity. What can we do about this important issue from both a global perspective and also from the point of view of countries such as mine? And I'm going to use the illustrative case example of Pakistan as I make the case for how we can scale up. So Pakistan, as you know, ladies and gentlemen, is a country with over 240 million population, and we have been trying hard to reduce newborn mortality for several decades now. But as you can see from this graphic, our progress in this has lagged behind other countries in the region. And currently, the neonatal mortality rates around 40 per 1,000 live births. We are widely regarded as a country where progress could be accelerated. And this is in the background of a lot of information available in the country around the etiology of newborn deaths, its timing. And let me share a few of those with you from the lens of a large national mortality analysis that was undertaken just a few years ago, right after COVID. And this looked at a sample size of a mortality assessment by districts, which used a national sampling frame provided by the Federal Bureau of Statistics, and looked at the distribution of causes of death in children under 5, in addition to other age groups that I will not go through today. So roughly, amongst children under 5, about 56% of the burden is in the newborn period. And the 3 disorders that you see outlined here, infections, asphyxia, and prematurity, account for close to around 3/4 of the entire burden. If you look at early neonatal deaths, perinatal asphyxia, and prematurity account for about 65% of all early neonatal deaths in Pakistan. And of those, there is an overlap between prematurity and other etiologies such as infections. Many of these deaths are very early. If you look at the distribution of neonatal mortality from this national analysis, a large proportion of these deaths are within the first 24 to 48 hours after birth, which also tells you as to where interventions and focus in the health systems has got to be in reaching some of these small premature babies and others who may be not just premature, but also growth retarded. When you go to the late neonatal period, a large proportion of these deaths are related to infections. And this also has a pretty significant overlap between babies who are small and vulnerable and may therefore be at a high risk of infections beyond the first week of life. In the last few years, we have looked at the terminology changing from just prematurity to small vulnerable newborn babies. And these are babies who are both small and premature, but could also be premature and growth retarded. And it is probably easier to understand this in a graphic assessment of risks of this particular category of infants in relation to maternal risk factors as well as other environmental risk factors. So if you take maternal undernutrition and pregnancy morbidity, this can lead directly to premature births, but it can also lead to fetal growth restriction. And you can see the overlap between the categories in terms of babies who are both preterm and growth retarded. These are clinically at times indistinguishable. As you can see, these two babies are the same size, but one is mature and the other one is preterm, pure preterm. And therefore, we have to recognize this entire category of preterm babies as well as those who are born small and the overlap as a category of small vulnerable newborn babies who are at excess risk of mortality. Now, what is the proportion of this in low and middle income countries? Increasingly, we are beginning to recognize that this category is a little more disaggregated than just simple low birth weight. This rather complex diagram tells you that you could be low birth weight under this particular line, but you could be low birth weight because you are preterm but appropriate for gestational age, or preterm and growth retarded, or growth retarded but not preterm. And therefore, categorizing these infants in these categories allows you to target and develop interventions appropriate to those particular subgroups. In Pakistan, we had virtually no data on this other than recently, in which a large population study in these two districts has prospectively followed up close to around 5,000 live births with determination of gestation and determination of birth weight. And what I can tell you that amongst the deaths that were recorded in this particular area with a relatively high neonatal mortality rate, roughly about 47% were in the category of preterm and small babies. And if you take the additional category of 20% who are just small for gestational age but not preterm, about 67% of all deaths in these small babies were in this category of small vulnerable newborn infants. But these are not the only ones. And in the context of newborn care, about a third of all deaths take place in relatively larger term babies and those who are not low birth weight. So in categorizing the target groups, this figure of 2/3 being small vulnerable newborn babies is important in our context. So what can be done? So I'm going to share with you some recent evidence updates that will be hopefully forthcoming early next year as part of the Lancet Newborn series, which we are updating since the last time it was done in 2014. And I'm going to try and summarize a large body of information through the context of how we are targeting interventions in relation to pregnancy. So there are obviously many cross-cutting and multiple level interventions, including regionalization of health services, transportation, but our principal packages of care remain the same. Those that are at primary community level, those that are at secondary facilities, and then a proportion that are delivered in tertiary level intensive care settings. The advance that we have made in understanding how these intervention works are in trying to recognize where they have maximum effectiveness. And here, early antenatal care or care before 20 weeks of gestation becomes extremely important because several interventions that I will briefly mention are only truly effective if you deliver them early in pregnancy, which means that we need to target putting most of the antenatal care early access effort in the first 20 weeks of pregnancy. And then there are, of course, those which are related to immediate and early newborn care, characterized by where deaths are clustered, and then an increasing recognition of the importance of continued care beyond the neonatal period into early infancy. So what are these interventions that we think can make a difference in terms of preventing and also improving newborn outcomes? There are a large number of interventions which are early, targeted, and they improve both growth retardation and also prematurity. And provision of multiple micronutrients or appropriate nutrition to women who may be deficient and also of low BMI has been shown to have significant impacts in terms of reduction of prematurity and also growth retardation. And you will see that there are also emerging interventions, both in relation to appropriate nutrition, like with omega-3 fatty acids, with the data largely coming from high-income settings, with a reduction in prematurity rates of up to 11%, and also the importance in malaria endemic areas of starting treatment early with a reduction in adverse outcomes in pregnancy. There are several things that cannot be done at community level, which was the previous slide, but they need to be done in the context of a functioning health system and primary care health facilities. And these relate to the prevention of preeclampsia and the provision of interventions like low-dose aspirin for those women who are at high risk of preeclampsia. And this has also been shown to reduce prematurity by as high as 14%. And appropriate detection and management of maternal morbidities like diabetes are also associated with an important significant reduction in the risk of prematurity. This is obviously in addition to other interventions that we recognize are important in terms of reducing adverse outcomes like prevention of smoking and screening and early treatment of asymptomatic bacteriuria or asymptomatic urinary tract infections in women. When you go to the late antenatal period or near-term care, as Dr. Banerjee has mentioned, the overwhelming evidence around the effectiveness of antenatal corticosteroids in health facilities, if administered properly, and now proven through large multi-center studies in terms of their impact on neonatal mortality, also goes through a prematurity pathway. So it accelerates lung maturation and also reduces the risk of neonatal mortality by as high as 22% seen in this overall analysis. And of course, appropriate treatment of mild to moderate hypertensive disease in pregnancy has also been shown to be associated with improved outcomes in small vulnerable newborn babies. The crux is, of course, in immediate early newborn care. And here, ladies and gentlemen, in addition to the essential newborn care that needs to be provided for all babies, the important take-home message here is the importance of facility births. And delivering in a facility that is able to provide early stabilization, immediate kangaroo mother care has been shown to reduce neonatal mortality risk by as high as 22% and is also associated with improved developmental outcomes, in our opinion. This is also associated with interventions that can be delivered early in some settings, such as, for example, the use of cord chlorhexidine where births are in unclean environment, and also the use of delayed cord clamping in preterm newborn babies, which has been shown to have some benefits, even though mortality effects may not be readily apparent. When you go beyond these immediate stabilization and essential care, the evidence in support of being able to provide respiratory care to babies who need it, preterm babies with respiratory distress, the evidence in support of provision of nasal CPAP or bubble CPAP is extremely strong and has been shown to reduce treatment failure and improve perinatal outcomes with reduced risk of mortality in several studies in low and middle income countries. And we believe that this is an intervention that needs to be made available now in every district secondary hospital capable of providing newborn care. The additional benefit, of course, in a small subproportion that do not respond or are extremely preterm would be with the provision of surfactant, but that can be restricted to neonatal intensive care units or tertiary settings. Finally, a word about feeding, appropriate nutrition, and the bottom line take-home message here is that in addition to the benefits on mortality and outcomes of early initiation of breastfeeding, we have clear evidence of high rates of adverse outcomes with the use of formula milk in comparison with maternal breast milk from a range of studies done in low and middle income countries. So we believe, therefore, that provision of mother's own breast milk, either directly to the baby through means of feeding or through the use of appropriate, culturally appropriate breast milk banks, would be one important intervention in these high-risk newborn babies. Let me, towards the end, just give you a snapshot as to how this may impact outcomes. And again, I'm going to use the context of Pakistan and to tell you exactly how we believe through the LifeSafe tool model, for example, that these new interventions could impact mortality. So here in a nutshell are the number of newborn deaths that can be averted by the year 2030 or 2035. Close to 2/3 of all newborn deaths using these simple interventions that I've mentioned could be averted if they were implemented at scale across the various regions. Of these, the best impact, the maximal benefit that you're seeing are in the two interventions outlined, two causes of mortality that you see outlined here. Prematurity deaths and asphyxia-related deaths could be substantially reduced from 2024 current figures by 2030 and 2035 if we were able to implement that at scale. And to those who think that this can only be done in tertiary settings, here are what the data tell you, that the secondary care package, which is the package in your district headquarter hospitals, from the interventions that I've told you, could avert a large proportion of these deaths without necessarily getting everybody to a neonatal tertiary facility in a provincial capital. So the benefits of primary care packages at community settings and also adequate secondary care packages with high quality newborn care in district special care units is pretty strong in the context of Pakistan in terms of aversion of almost 2/3 of preventable newborn deaths. So ladies and gentlemen, let me finish by saying that this is not just a moral imperative in Pakistan, it's an absolute prerequisite in our addressing the Sustainable Development Goals and our development of human capital. This can be done through outreach programs and community outreach and mobilization, especially in reaching marginalized populations and hard-to-reach populations in our rural districts, and can be done through appropriate primary care, appropriate referral systems, and quality secondary newborn care in the district facilities that I have just mentioned. It will require training of human resource, it will require provision of services, but that's where we need to focus our attention. But it requires, in order to do this, the resources and, importantly, the political will to prioritize appropriate newborn care and accountability. And accountability requires changing mindsets. So let me finish by citing from one of my public health heroes, Dr. Muhammad Yunus, who a long time ago said that my greatest challenge has been to change the mindset of people. Mindsets play strange tricks on us. We see things the way our minds have instructed our eyes to see. And I hope, ladies and gentlemen, that with this new evidence, we can look at the intractable issue of prematurity through fresh mindsets and fresh eyes. Thank you.
Thank you very much, Sulfi, and also for giving us a sneak preview of the series that's going to come out next year. Very enlightening. Maybe just to highlight some other pieces of guidance that are going to come out. WHO and UNICEF have been working on an implementation guidance on norms of care, looking at, for example, what is the health workforce needed in a premature unit, in a small and sick newborn care unit, what's the space that's needed, referral time, etc., etc. And that's going to come out early 2025. And WHO will also come out with an operational guidance on kangaroo mother care for health workers. Let's go to our next item on the agenda. And we have Dr. Mariam Sarfraz from the Ministry of Health in Pakistan. And she's going to talk about her experience in moving the small and sick newborn agenda forward in Pakistan.
Good evening, and thank you very much for the invite. And I realized that we have a very packed agenda, and I was told that I have just 10 minutes to really go over some of the key progress which has been done in Pakistan. So if I can have the next slide, please. I'll just briefly put the context for everyone. Pakistan is a large country in South Asia. We have 4 provinces, and we also have a federal form of government, which has the capital plus 3 regions, which you see up in the north. We have a large number of districts. The reason we have mentioned the number of districts here is that if you recall Dr. Bhutta's Bhutta had kind of said that we need to have small sick newborn care units in every district, and that's the reason I've put the number of districts here. For a little bit of a context about the population and the number of births, we have approximately 6 million births happening every year among 51 million women of reproductive age between the ages of 15 to 49 years. And we have a very rapidly growing population currently at 241 million. Plus, we have a high growth rate. The TFR right now is at 3.2, 3.3, and our growth rate is also I think it's nearly 2.4, 2.3. I'm not sure about that, but we are still yet to reach the replacement level fertility. Next slide, please. So in terms of the key indicators with reference to the World Prematurity Day, we have a high neonatal mortality rate of 42 per thousand live births. And that's 7% of all newborn deaths globally. We have 86,000 premature births every year. And this is based on estimates because we have an issue with the data and information systems within the country. And unfortunately, we are the second country that accounts for nearly 2/3 of all the deaths from the preterm births and complications. Next slide, please. So I will not go into this slide as this is something which Dr. Bhutta has already shared as to the reasons and the major mortality among which group of infants is there. So if I can have the next slide. This slide also, Dr. Bhutta had covered it, that we have an increasing trend of antenatal care visits, but the quality and the quantity are, they vary by the wealth quintiles and also by the province, because like I said, in the context that Pakistan is a large country, not just in terms of the numbers, but also geographically, with the province of Punjab being the most developed. If you see on the right hand of the slide, you have a bar graph, which shows the antenatal care visits. So Punjab is the largest province in terms of population, and in terms of the inputs which go into the health systems, Punjab puts in a bigger budget than other provinces, and the coverage is much better over there. There's a higher usage of antenatal care there, and in one of the northern regions of Azad Jammu and Kashmir. I can have the next slide, please. Among the challenges, we have several opportunities. One of them is that we have a good political commitment right now from all the provinces and the regions. But the gap there is that this political commitment is yet to translate into financial investments and more funds being put into health, and especially into maternal and newborn health. We also have a devolved health system. We don't have a centralized way where the federal controls or has a policy and then gives the budget to all the provinces, but the provinces are independent to make their own policies and invest as per their needs or based on certain evidences which have been identified in the Universal Health Coverage Benefit Package. Along with that, we had a national health vision, which was from 2018 to 2025. It had certain key pillars, 8 key pillars within it. One of them was maternal and newborn health. And since the time for the framework was 10 years and it is next year drawing to a close, we have already started the process of developing the new National Health and Population Policy. This was one of the recommendations which had come up, that health and population should be dealt with together and not have separate documents. So this is something which is in process, and the reason I am emphasizing the inclusion of population is a challenge which I will come to later on in the talk. We've also had a better access and quality of services which are focused on small sick newborn care. And this includes development of kangaroo mother care intervention and the KMC units being developed in a lot more district level health facilities, including a recent initiative of having a KMC in a private sector hospital. We have strengthening efforts going on for the health facilities which have small secure newborn care units in terms of training of the doctors or the nurses or provision of equipment. The home-based newborn care system has also scaled up in some districts, and it is showing promising results. The point of care quality improvement initiatives have also been introduced, but this is just as yet at a very early stage, and I cannot yet share any results for that. Next slide, please. So in terms of the government ownership or the political commitment, there are several documents, strategies, policy frameworks which have been developed. The key among them are on the top right is the newborn survival strategy, which has a costed action plan, and it kind of really gives a good figure or a number or a layout of what a small sick newborn care unit at a district level should look like and what it would cost the government to really put up or make functional in the place. The second one is the lower right-hand corner, the EMOC care guidelines. Based on these guidelines, there is certain progress, which includes training of the healthcare providers. It includes referral pathway and the referral network development. And the most recent of them is the, again, bottom right, the antenatal corticosteroid guidelines. We did not have any specific for the country, but now we have them, and there is a linked activity to it, which I would come to in the next slide. So can I have the next slide, please? Again, here, certain ongoing initiatives regarding maternal nutrition strategy, the small sick newborn care guidelines and tools, and you would find that we also have a quality of care for RM and CH framework there. What lacks is the implementation, and implementation, of course, requires financial investments. Next slide, please. So the key milestones, like I've already referred to in the previous slides, we have the newborn survival strategy with the costed action plan. We have national guidelines and training package on small sick newborn care. And there is training and work going on in the country across the provinces. And we also have a pool of master trainers, which has been developed at the national and provincial level. And these master trainers are tasked with initiating the trickle-down trainings. Next slide, please. So this picture has been put up just to showcase really that we've had joint action planning workshops and discussions in all the provinces with reference to the formerly the ENAP and now the Every Woman, Every Newborn, Everywhere initiative. Next slide, please. In terms of the targets, so the first target of ANC coverage, we have really more than 90%, nearly 90% coverage. And the progress to date is listed here in the form of certain activities or initiatives which have been done. These include the integration of the guidelines in the national comprehensive SRH guideline, provincial capacity development, implementation on the, and supportive supervision is being provided through master trainers, through mentors. There's a national pool of master trainers being enrolled and developed as well. We also have midwifery, the first ever bachelor's of midwifery program initiated in the country, and we've inducted the second batch of students into that. Next slide, please. So there is also some initiative because while the country, although huge and everything, so we also have a wide disparity among the wealth quintiles, and there are inequities associated with that. So to address those, there are certain initiatives ongoing, which include the home-based newborn care in almost nearly 70 districts in the country. We also have an advocacy planning, capacity buildings, and service delivery, monitoring, evaluation, supportive supervision options available for various levels. There is the ongoing initiative of strengthening the antenatal care, stillbirth attendance, postnatal care, and newborn follow-up and referral mechanisms at the village, at the community level. Next slide, please. The target 4 of this initiative, that 80% of country districts can access EMOC and small sick newborn care services. So next slide, please. So in this regard, we are yet to catch up or make some kind of a headway in that. Not that we don't have any progress. We are progressing well in that. We have developed small sick newborn care units at some districts. And there is a lot of work going on in terms of developing those or providing the needed support to the districts to establish their own small sick newborn care unit at least at the district level. There is a training package in place. There have been several trainings. And additionally, there is a software which has been developed for reporting the perinatal death and surveillance and response for that. Then referral strategy development is in progress. We have a national midwifery strategic framework, a nursing and midwifery policy framework in place. There are district implementation plans for EMOC strengthening available, and these include the strengthening the small sick newborn care at the district level. Next slide, please. We are also showcasing here today the scaling up of evidence-based interventions across the country. You would see here in the map in the middle of the slide bottom, the orange dots, they show the kangaroo mother care units, which have been scaled up and provided across the country. There are 84 districts out of the 166 which have a KMC, a functional KMC at several hospitals within the districts, and there is continuous efforts going on to sustain them, to develop the human resources, to provide the care in those KMCs. There are now, so far, you can see that more than 20,000 newborns have benefited from the KMC services, and community KMC is now that's the next step in upgrading or implementing a cost-effective intervention. That community KMC initiative is now being given extra attention, and we are trying to work and develop that. Next slide, please. You can also see that more than 64 health facilities have small and sick newborn care units, and these have been some are through the government support, some have been supported by WHO and UNICEF. We've also had very successful initiatives like solarization of the health facilities, which initially started with the concept of ensuring that oxygen supply is maintained while there are electricity outages due to many reasons, and solarization helped that. But it has also had a very positive impact on providing and enhancing the quality of care for the small and sick newborn care units. Next slide, please. We're developing very
Sorry, you
strong.
still have 2 minutes. Sorry to interject.
Yes, I am coming to a close.
Thank you.
Thank you. Thank you for the reminder. So I will not go over this, and you can see the guidelines here, and we will share the links for them as well. Next slide, please. What I do want to say is that we need to strengthen the data systems, because the units which have some intervention, some support going on, or some kind of a research activity, they have really good record keeping. They have really good information available on the newborns and the births there, and the outcomes of those newborns. But this is a big gap which we are trying to strengthen and work on. Next slide, please. EMOC implementation is in process happening, and like I said, we have provincial implementation plans in progress. Next slide, please. In terms of the research, the thing I really want to showcase is that there is right now implementation research on use of antenatal corticosteroids and scaling up small and sick newborn care units in the country going on right now. We are doing this in Haripur and have been quite successful in ensuring the right and appropriate use of corticosteroids for mothers who are expected to have low birth weight babies or preterm labor. Additionally, we have scaled up the small sick newborn care unit. You can see the pictures here in the Haripur district headquarter hospital with support from WHO. We're now going to be right now we are planning the scale up of the same initiative in at least 10 more districts. So that's something which is really, would bring out good evidence in terms of the implementation or the gaps therein. Next slide, please. Community engagement activities have also been scaled up with some additional documents available for the community health workers. Next slide. Private sector is continually engaged in implementing the same standards of care which are there for public sector and which have some global evidence behind them. Please, next slide. These commemoration activities, they go on across the facilities to remind people of the importance of these initiatives. Next slide, please. The challenges. Now, this is the most important for us right now. The biggest, Dr. Bhutta has highlighted quite a lot of them, which include malnutrition, which include early newborn care, which include preterm care for and interpregnancy care for the women. The two other things which I really want to emphasize, one is the low uptake of family planning, which is really affecting the interpregnancy interval. And second is the vulnerability of Pakistan by the climate change. We have floods, we have heat waves, we have other similar weather changes or challenges happening, which now we have evidence from across the globe, and 2 studies from Pakistan, which really show that increasing temperatures and malnutrition are affecting the birth and the outcomes of pregnancy outcomes as well. So I will leave this slide on, and thank you very much for giving us the time to showcase and to highlight the challenges which we have at hand. Thank you very much.
Thank you very much, Dr. Sarfraz, and particularly for highlighting how you've taken policy into, let's say, guidance, implementation, now looking at scaling up. So I think a lot to learn from what's happening in Pakistan. We will go next to why we need to invest in small and sick newborn care and why we should do it now. And I hand over to Dr. Leah Greenspan, who is the Senior Newborn Advisor at USAID. Over to you.
Thank you so much. I want to say thank you to WHO for inviting USAID to speak on behalf of newborns, especially those that are small, sick, or stillborn on this important World Prematurity Day. This is a very special and important day. I want to highlight and thank the government of Tanzania for proposing that World Prematurity Day become an official WHO day. Data and trends information has been already shared by the previous speakers, but I want to emphasize that in 2020, a baby died every 40 seconds due to complications of prematurity, with 80% of preterm births occurring in LMIC settings. There are 30 million newborns that need facility-based care, and 80% of them do not receive it. It is these trends and data that have created global awareness and have shaped USAID's strategy and investments. The time is now, right now, as over 60 countries are off track to meet the SDGs for neonatal mortality. We have 5 years left till 2030. We must expand investments to not only strengthen care for all newborns, but to also focus on those that are small and sick. And to do that, we must strengthen the health systems that provide their care. Over the last 2 decades, the #1 cause of global neonatal mortality has shifted from intrapartum-related events to prematurity, thanks to the tremendous work of global partners' efforts to improve care around the time of delivery. On this day, World Prematurity Day, we are coming together to bring additional awareness and investments to strengthen quality small and sick newborn care. USAID from the global and country level use our boots on the ground to operationalize the WHO and UNICEF small and sick newborn model of care, a model of care that was developed with the brainpower and expertise of many people across the world. And I am humbled that our team was part of that important work in developing this model. At USAID, we are prioritizing our funding to support care for all newborns, prevention of stillbirths, infection prevention and management, operationalizing the WHO-UNICEF small and sick newborn model of care through the health system lens with a focus on commodities, strengthening oxygen ecosystems, and data to drive change. all on the backdrop of a nurturing, developmentally respectful environment. I want to thank you again for the invitation to speak today and support this important day. Back to you. Thank you.
Thank you very much. And so we will now go to the next session, which is Q&A. And we have a couple of Q&A questions already. And I think, Sophie, two for you maybe. One particularly around the impact of climate change and air pollution on the outcomes for newborn health, as well as there's a question whether you could highlight something about the independent evaluation initiatives that are being prepared.
Okay, I need a little bit of clarification for the second question. Independent evaluation initiatives for what? National level
It
data or
says that
global?
are being prepared or in course to assess the effectiveness of packages of interventions implemented under real-life conditions.
Ah, okay, all right, I got it. So on the first one, absolutely. I think work is underway in terms of also developing attribution models for climate, particularly in relation to newborn health. As you can probably surmise, over the last 1 year, there have been several publications that have highlighted the impact of heat and also heat and humidity on adverse newborn outcomes, adverse pregnancy outcomes, perinatal mortality, stillbirths, neonatal mortality. Attribution work is relatively limited, and the bit that we have gives figures as high as 4% of neonatal mortality related to climate change or heat effects in Africa. So we need more work on this, but it's clearly emerging as a very important area where the pathways for adverse outcomes may be related to the impact on the mother during pregnancy, with increased risk of small vulnerable newborn births and perinatal mortality. On air pollution, the evidence has been there for a long time that certainly indoor air pollution and excess exposure to smoke can be associated with increased risk of stillbirths and increased risk of low birth weight births. But the evidence around the interface of climate and air quality is as yet lacking. And that is work that needs to be done in real life situations in providing some attribution figures. Bottom line, these are important interventions, and these will be integrated within prevention and mitigation strategies to address adverse newborn outcomes. On the real life evaluations, absolutely. I think there are parallel exercises underway, which in addition to the traditional way where we look at evidence through systematic reviews, meta-analyses, and modeling, are now beginning to look at experience through the exemplar lens, which is which countries have done well. And if they've done well in terms of reducing maternal and newborn mortality, what has been the pathway to that improvement that allows us through methods such as, for example, trend analysis, decompositions, to attribute success to one or the other elements of the investment. Those studies have just been published. Some of them have just been published around the exemplars for neonatal mortality. And they provide very interesting insights into how countries have transitioned from one level of care to the other, with improvements in facility births, improvements in transfers to higher levels within the health systems, and also improved quality of care within health facilities. As you're well aware, there is a difference between efficacy and effectiveness. And many of the evidence reviews that we have now increasingly try and look at large-scale trials just in order to capture that depreciation of effect between efficacy and effectiveness. To cut a long story short, you'll be hearing a lot more about this over the years. But the good news is that no matter what the types of evaluation, the direction of travel is the same. That scaling up quality care in district health systems with appropriate linkages to primary and community care is the key to making things work. And many countries that have reduced maternal and newborn mortality have done it through that systematic process, but in an orderly manner over time. The challenge for all of us is how can we do this faster? Thank you.
Thank you so much, Sophie. And we have another question, and maybe Dr. Sarfraz, you might be the right person to respond to those from a country experience perspective. One is what you think the greatest challenges for the healthcare workers in order to deliver quality of care. And the other one in relation to CPAP and the link with antenatal corticosteroids, and whether at the district level you're able to ensure that you're able to implement both of those. Thank you. Over to you.
All right, thank you very much. So first about the challenges, the biggest challenge right now, there are several initiatives which are going on for the capacity development. So while we have these master trainer trainings where the healthcare providers are brought together with experts and with some kind of model equipment to deliver them the skills and tell them how to really operate, let's say, a CPAP machine or make a bubble CPAP or other related interventions and their delivery. But the challenge therein is that when they go back to their own workplaces, they lack the equipment over there to really provide the skills which they have learned. So that is one challenge for us. And the equipment is expensive. It is not very widely available in the country. It is mostly available in large teaching hospitals. There are some initiatives going on to remedy that. The second is we are right now facing a very big brain drain, especially in terms of the demand of the healthcare workers in better developed countries, in neighboring countries, especially in the Middle Eastern countries. So we have an en masse kind of a migration of healthcare providers, especially doctors and nurses, and more so for the nurses who are very well trained to provide the patient care. In terms of the second question with regarding the antenatal care, antenatal corticosteroids and CPAP, so we have been pretty successful in doing this at a level 2B health facility in District Haripur. Haripur does not have a teaching hospital, but what it does have is a district health headquarter hospital, which has the doctors, pediatricians, and what we lacked in terms of neonatologists over there, we made up by training the pediatricians and the pediatric nurses on caring for the newborns. So that's kind of a work transfer kind of a thing which we did. We have given them the skills. With the help of UNICEF and WHO, we have also provided them with CPAP machines, given them training. We've got mentors who visit them. Now we've also identified local champions. So it's not that it has yet become a habit, but with some supportive supervision and regular monitoring, we have been able to showcase that that appropriate corticosteroid use by measuring the birth gestational age. I'm sorry, I'm not a clinician, so I forget these terms. The gestational age using ultrasounds and then determining what dose and when to give. So that's something we have been successful in showcasing, and we are in the process of now writing up those findings. And you might have, I work with Aisha DaCosta and Yonis in doing this work, and Pakistan has been successful, and that's the reason we are now going to scale it up in 10 more districts, which are similarly which have similar inadequate in terms of resources and pediatricians and neonatologists. I hope I've been able to answer. Thank you.
Thank you. Thank you very much. And now we're coming to the closing sessions, and we'll first have Dr. Gagan Gupta, who's the Senior Advisor, Maternal Newborn Health at UNICEF, to talk about adapting to changing needs of the newborn landscape. And he'll be followed by Dr. Fawzia Shafiq, who's the Associate Director for Health at UNICEF, with her closing reflections on the session today. Gagan, over to you.
Thank you, Anshu. Am I audible?
Yes.
Thanks. And thank you so much, Anshu, and to all the speakers. And over the next 7-8 minutes, I will try to take you through how the global community is adapting to the changing needs of the newborn program priorities and moving beyond just essential newborn care and sepsis management, which was the main focus in the first 20 years of the century. But don't get me wrong, essential newborn care and sepsis management still remains very critical, but we need to build beyond the foundation of this. And this is driven by two main things. One is the 80% increase in the institution delivery, as Leah said, since 2000, and the changing pattern of newborn mortality with prematurity, especially in South and East Asia region, becoming a significant rise since the last 10 to 15 years. And also on the rise is congenital malformation, which will also involve more investments into specialized care. Now, the first thing was in 2019 when the global community came together to define the levels of newborn care, which led to level 1 newborn care, level 2, and level 3. The second important thing was in 2022 when WHO came out with wonderful guidelines on the care of preterm and low birth weight babies. And the major shift in this was IKMC, which is the immediate KMC, even for unstable babies. A strong recommendation for caffeine citrate, family involvement in care, and home visits by the trained health worker for the follow-up of the discharges from the newborn care unit. The third important thing which is in the pipeline and is more forward-looking is the revision in the EMOC signal functions with a very strong N component. In the 2009 framework, N was just neonatal resuscitation, but the new framework, which is expected in a couple of months from now, will have full package of level 2 care at the CMOC level and level 1 care at the BMOC level. The fourth important adaptation was introduction of a target in the ENAP coverage targets, focusing on small and sick newborn care. And we heard from Pakistan how effectively they are trying to push the district level coverage of level 2 newborn care units with CPAP. But one major thing which we need to address as a global community is the level of planning and the level of ambition is not matching the target. Especially if you see in sub-Saharan Africa, only 33% countries have planned for a 80% coverage. And when we look at implementation, in sub-Saharan Africa, only 10% countries have achieved it. South Asia has done comparatively better with 57%, largely because of the numbers from India, Bangladesh, Pakistan, who have done very well on this particular aspect. The fifth important thing is the upcoming guidance from WHO UNICEF on norms for small and sick newborn care units. Anshu made a mention of it. This will include the number of beds needed. It will include the minimum space requirement for the beds and will include the human resource which is required to run these newborn care units. And you can expect them as early as January, February next year. Now, two important issues which remain as a weak link, and that is the family involvement in care. Mothers and parents are not visitors to newborn care unit, and this brings the whole aspect of getting the birth companion in the labor room, the breastfeeding support, and the psychological support. And the last point before I conclude is the post-discharge follow-up of these small and sick babies. Because once the babies are discharged, they still need support for survival, growth, and development. And that is important to link with the early childhood development. So I would like to conclude with this image where counseling on discharge, home visits by the community worker, and again a follow-up at the health facility needs to happen. Thank you so much, Anshu, for inviting us, and thanks to everyone. With this, I hand it over back to you.
Hosea, over to you.
Thanks, Anshu. Many thanks to our speakers and for extremely useful and very thought-provoking information and updates. Before I summarize with what we would like our participants to take home with them, I did want to remind us all that there's nothing quite as heartbreaking as seeing a mother, any mother, but especially a mother that comes from a remote, vulnerable community, from a family that faces all kinds of hardships. For such a mother to go through a pregnancy and all the accompanying difficulties that a pregnancy brings for a mother, and then to deliver a preterm baby who either succumbs to all the complications of prematurity or faces its medium and long-term consequences. And therefore, to repeat Dr. Tedros's message, this is a really important day, and I'm glad that we were able to come together and to think of these mothers and their premature babies. Colleagues, 5 things that we would like you to take home with you after having listened to the speakers today and the very interesting and useful questions that were asked. Before I mention these, I do see a couple of hands still up, and I see that our speakers are answering questions in the chat box. So if you those colleagues who have your hands up, if you still have pending questions, please do put them in, and our speakers will respond to them. And if we are unable to get to any of the questions, we'd be happy to follow up via follow-up email. So the few takeaways. One is, remember the numbers. The numbers really are staggering. 13 million preterm babies born every year, and prematurity now being the #1 cause of newborn deaths, accounting for around 37% of all these deaths. Second message to please remember is that many of these premature births can be prevented through focus, as Dr. Bhutta was saying, on maternal malnutrition, through ensuring that we attempt to delay the age at which adolescents and young women have their children, through ensuring high quality antenatal care coverage, and all the other measures that were mentioned on prevention. Many of these premature births can be prevented if action is taken timely. The third take-home message is that there are interventions around facility-based deliveries that can help these babies. Kangaroo mother care was mentioned, early and exclusive breastfeeding was mentioned, and these are crucial to improving the survival rates of the preterm babies. And linked to that, of course, where required, newborn units that provide PAP and other services. Fourth, as Gagan just mentioned, traditionally we've talked about the baby only when we talk about preterm birth, but we now realize that the care for the preterm babies needs to be linked to the psychosocial support that the parents and the family require for themselves and to be able to take better care of the baby. And then finally, the need for both long-term, medium-term, and long-term follow-up for both growth and development monitoring and support for these babies. It's timely that we are having the webinar today. Many of the speakers and the organizers, we are in Dakar, Senegal, where we are 25 countries, ministries of health delegations, and our partners are coming together to work on maternal, newborn, and child survival acceleration plans, where, of course, the focus on small, sick, and premature babies will be high on our priority list. And so let me conclude by saying that as part of the IVENI partnership, the UN agencies, our partners, remain fully committed to working with you on preventing all newborn deaths, including those that result from prematurity, and remain committed to working with all our country colleagues in making sure that these plans are accelerated and that we make further progress faster towards these goals. With that, let me wish you all a very happy rest of the day and success in your endeavors towards working on reducing newborn mortality. Thank you, colleagues, and goodbye. Olive, I see your hand up.
No, thank you so much, Fazia. Thanks to all the speakers. Thank you.
Thank you, colleagues. And thank you, speakers.
I'll be ending now, hanging on the call. Thank you, everyone, for making this happen. Have a good day in Dakar.
Thank you, Benny. Thank you, organizers.